So today, in the next 20 minutes or so, we will quickly talk about the relative merits and advantages of autologous transplant versus CAR T in aggressive B-cell lymphoma. So I modified the title a little bit. I'm going to talk about auto transplant versus CAR T cell in aggressive B-cell lymphoma patients who happen to have a sensitive relapse. And I'll come back and explain why I made that distinction. Uh, my disclosures, and some of these are relevant to this talk, are shown here. So just a quick relapse or sort of a recap about some historical perspective. And it's becoming historical, arguably, to a certain extent in practice, at least in the USA. But I want to remind you the setting where we approach and use and think about high dose therapy in autologous stem cell transplant. So when an aggressive lymphoma patient relapses, people who apply autologous transplant, you typically don't go and directly do autologous transplant in a relapsing aggressive lymphoma patient. Autologous transplant is not a treatment for patients with relapse aggressive lymphoma. It is merely a consolidation for relapsed aggressive lymphoma patients who happen to respond to second-line therapies. And that's why I modified the title of my talk and say, how do you approach CAR versus T-cell therapy in patients who relapse, but by chance they have already shown evidence of chemosensitive disease? And in such patients, our practice is based on its old data. It's almost 3 decades old, but the PALMA trial randomized relapsing aggressive lymphoma patients who happen to respond to second-line therapy to either no further therapy or consolidation with autologous transplant, and clearly showed both a progression-free survival benefit as well as an overall survival benefit. Now, we also know that every single patient who gets auto transplant, they don't benefit from these transplant. Over the years, based on some data from the CORAL trial, we have identified patients who are unlikely to benefit from this approach of chemotherapy salvage followed by auto transplant consolidation. And a clinically easy way to identify these patients is patients who relapse within 1 year of their diagnosis. And these patients, when treated with conventional salvage therapies, most of these patients do not respond to second-line salvage therapies like RICE or ICE or DHAP or things along those lines. And since more than half of the patients don't respond to currently available salvage treatment approaches, the event-free survival of these patients is about 3 months. This is nothing new. We have known about this fact for almost 12 years. Now, before better approaches were available, how did we approach patients with early relapsing disease? And patient can relapse early in 2 forms. You can either go into a remission and then relapse early, or you may fail R-CHOP from the get-go. Now, among patients who relapse early but happen to respond to second-line therapies, a CIBMTR analysis that we published almost 8 years ago showed that, yeah, we agree that if you relapse early, you have biologically bad disease. But if you happen to be the lucky patient who's going to respond to second-line therapy, these patients, if taken to autologous transplant, do okay. Their long-term outcomes are roughly comparable to long-term outcomes of patients who relapse late. Now, what about the second pattern of failure? Patients who are primary refractory. What about primary refractory patients? Well, even in the primary refractory setting, again, the key is if you're lucky enough to respond to second-line therapy, and I admit that it's a minority of patients, they happen to benefit from autologous stem cell transplant. These are some new data from CIBMTR replicating the observations that Julie Vos published almost 20 years ago now. Now, I'll be the first person to admit that these data are illusion for patient selection because the CIBMTR data is only capturing the lucky patients who respond to second-line treatment and then get consolidated with an autologous transplant. But if you look at all comers, primary refractory patients or patients who fail after an autologous stem cell transplant, their long-term outcomes are dismal, right? Their median survival is only about 6 months or so. And as a field, we haven't done a good job of at least until recently, of changing the natural history of these disease. We have looked at improving salvage therapies. We have looked at improving uh, autologous stem cell transplant platforms, but none of these approaches have clearly changed the standard of care of these patients. And that begged the question was, can you change the natural history of early relapsing patient by applying novel CAR T-cell based therapy in second line? And as your very learned group is aware that at the last ASH meeting, three large randomized trials were published, um, presented, and then subsequently published. And they were asking a simple question. If an aggressive lymphoma patient relapses early using a variation of definition of CORAL trial, should these patients be directly taken to CAR T-cell therapy, or is the standard approach of trying chemotherapy and then doing an autologous transplant and responding patient better? Now, there were nuances in these trials design. I'm not going to go into the weeds. Some trials allowed bridging therapies, other didn't. Some trials mandated bridging with platinum-based approach, and so on and so forth. The common thing in this trial is relatively similar inclusion criteria. All were using CD19-directed CAR T-cell therapy in the experimental arm. And all trials' primary endpoint was event-free survival, but the definitions varied across the trial. Now, all comers, two of the trials, Zuma-7 and Transform, using Axi-cell and Lysocell respectively, were positive study. They showed an event-free survival benefit. However, the Belinda trial was a negative trial for a variety of reasons. But the question that I'm trying to answer is, these trials unfortunately can be used to answer a basic clinical question is, if in 2022, assuming you have access to both therapies, a diffuse large B-cell lymphoma patient comes to your treatment center in a partial remission or a complete remission, how are we going to approach that patient? And the reason these trials can't answer this question is because in these trials, treatment assignment happened before establishing chemosensitivity. And it's an important point to make because there is obviously an obvious bias in the community about partially responding, relapsing aggressive lymphoma patients. So, and there's some oddities in these three randomized trials. If you look at these three randomized trials, about half of the patients getting salvage therapies in these trials responded to salvage attempts, identical to the response rates CORAL trial showed. But there is a reasonable drop-off in responding patients getting autologous transplants. If you take a deeper dive at Zuma trial, in Zuma trial, by central review, 90 patients responded in the standard of care arm to chemotherapy. According to investigators, 80 patients responded. So there were at least 10 partial responders that the treating investigator determined that these were not responding patients when in fact they were responding. And out of these 90 responding patients, only 60 responding patients ever got to an auto transplant, meaning after showing response to your ICE or DHAP or whichever salvage you were giving, a third of your patients never made it to an auto transplant, which is twice as high a failure rate than you have seen in historical comparable trials using identical therapies. And I think it is reflective of investigator bias that we are reluctant to take patients who were likely in partial remission to an autologous transplant. We just call these patient therapy failure and then move on to alternative approaches. Now, but the way these trials were conducted are a little different than real life patients, at least the way they come to transplant and cell therapy centers. I see patients who travel 2, 4, sometimes 5, 6 hours to come to Milwaukee. Sometimes their responding patient or physicians call me and say, hey, Dr. Hamadani, I have an aggressive lymphoma patient. He has explosive progression of disease. What do we do? And we usually say, well, give a cycle of ice and I'll see the patient in my clinic. So think about a hypothetical patient who had explosive progression of disease. And by the time the patient sees you, the patient is in a partial remission. How do we approach this patient? And unfortunately, these three randomized trials can't answer this question. And in CIBMTR, we were anticipating this problem because we knew this scenario is never going to be answered by these randomized trials. So we looked at a registry analysis where we looked at aggressive lymphoma patients who relapsed but were responding to second line therapy, meaning basically these patients were either getting CAR T cell treatment or autotransplant treatment after achieving a partial response to second or subsequent lines of therapies. We had about 260 such patients in autotransplant group and about 145 patients in the CAR T group. Their baseline characteristics are similar age, equal proportion of patients with double hit disease or primary refractory disease. But of course, the CAR T cell part of this study had one more prior line of therapy. Disease bulk appeared to be the same. And if we look at the outcomes of these partial responders getting either CAR or autotransplant, I'm not going to make an argument that autotransplant is a better treatment, but at least we can say that CAR outperforms an aggressive lymphoma patient who has already achieved a partial remission. Now, the criticism of this study is that CAR patients had one more prior line of therapy, so we did a subgroup analysis where we restricted the analysis to only 2 prior lines of therapy. And again, the analysis outcome is identical. At least we don't see an outcome favoring CAR. And when I show these data, the next criticism is, well, there are partial remissions and there are partial remissions. There are partial remissions where the residual disease is only a centimeter and partial remissions where the residual disease is more than 3 centimeters or bulky disease. But if we break down our CAR versus autotransplant comparisons according to the residual disease bulk, on the left, the residual disease bulk is less than 3 centimeters. In the middle, 3 to 5 centimeters. On the right side, more than 5 centimeters. Again, we don't see a clear trend where CAR outperforms autotransplant in partially responding patients. And maybe the CABMTR observations are an outlier. But if you look at the supplemental appendix of the ZUMA-7 trial in the NEJM paper, they give you this curves of duration of responders. So if somebody responded to salvage therapy in the standard of care arm, which is the green curve, if you look at their outcomes, they are very similar to the outcomes of CAR T cell therapy, meaning if you respond to salvage therapy, then the observations we are making in CABMTR are even potentially replicable in a randomized prospective trial. Now, the next provocative question is, we know partial remission patients do well, but what are you going to do with a patient who shows up at your door in a complete remission? If we look at the Memorial Sloan Kettering data, if a patient has a negative PET scan going into transplant, their cure rate with autologous transplant may approach almost 70% at the 4-year mark. Are we serving these patients well by taking all of these completely responding patients to CAR T cell therapy over an auto transplant? So some food for thought. Now, what about cost? And cost estimates are all over the place. When Kite did their cost analysis, Axicell appears to be cost effective. But when Dana-Farber did the same analysis, the cost estimates are 4 or 5 times the cost estimates from the Kite analysis, because the assumptions that go into those models are different. So the next concept becomes, well, should we do auto transplant in every single partially responding patient, even in year 2020? And I would be the first person to admit that no one size never fits all. So you have to make a decision for the patient you're seeing in your clinic. So let's talk about biologically super high risk disease. So this is a very important study that Alex Herrera and Philippe Armand did several years ago, where they looked at auto transplant outcomes of patients with what we call double hit lymphomas. And these are all chemosensitive patients. And you can see that despite chemosensitivity, the long-term cure rate with auto transplant in double hit lymphomas is in the maybe 25% to 28% ballpark. So if I see a double hit lymphoma patient in 2020 who relapses, and by the time they see me, they're already in a partial remission, I may still go the route of cell therapy in these patients. Then there is another prognostic scoring system that us and Luciano Costa developed in the REFINE analysis. And the REFINE analysis looked at only high-risk patients who relapse within 1 year of their diagnosis. And we identified 3 prognostic factors. A, patients who were progressing on getting R-CHOP therapy. patients with high IPI score, or patients with c-MYC rearrangement, regardless of their partner gene rearrangement. We identified these as 3 additional risk factors among early responding patients. And patients who have 2 of these 3 risk factors, even with an auto transplant, their long-term progression-free survival is dismal. So if I see a patient who meets refined study criteria, high-risk patient, despite chemosensitive disease, I'm unlikely to offer that patient an autologous transplant. And then, remember, lymphoma is a disease of older individuals. What are you going to do with a 75-year-old patient who's going to land up in your clinic with relapsed disease, or a 79-year-old patient? Harder to give beam and autotransplant to such patients. And for these patients, the observations of pilot trial are important. So pilot trial enrolled relapsing diffuse large B-cell lymphoma patients who were not candidates for autotransplant because they were older than 70 years of age or they had organ dysfunction. And in these patients, applying lysocell in second line was highly active. The response rates approach almost 80%. And these responses, at least in complete responders, appear to be durable. So we are in an exciting time where we now have the luxury to maybe think about a risk-adapted approach. So if you ask me, in relapsing diffuse large B-cell lymphoma patients, are we considering auto transplant for every single patient that walks through the door? And the answer is no. Are we considering CAR T-cell therapy for every single patient that walks through the door? And again, the honest answer is no. At least in our program as a group, we sat down together. I led a meeting where we said, okay, how are we going to approach aggressive B-cell lymphoma patients after the approval of Axi-cell in second line and Lysocell in second line for both early relapsing patients as well as patients who are not transplant candidates? So there is obviously room for improvement, but if we see an aggressive lymphoma patient that relapses, our first question is, does the patient have any known adverse high-risk features? Does the patient have double or triple hit lymphoma? Does the patient have refined, defined high-risk disease? Are the patients even fit to be considered for high-dose therapy or autologous stem cell transplant? Do they have primary progressive disease? And if the answer to all these questions is no, I still attempt salvage therapy and take responding patients to an auto transplant. In addition, patients who come to my practice after starting salvage treatment in the community setting, and by the time they see me, if they're already in a complete remission or a partial remission, we absolutely consider high-dose therapy and autologous transplant in patients who are candidates for these therapies. Now, if the patients have these high-risk features available, then of course CAR T-cell treatment is available as standard of care in the second-line setting, and I think these patients should be considered for this very important treatment approach. And in my opinion, I think more patients in second-line treatment will get CAR T-cell treatment compared to auto transplant. That's common sense. But I think this risk-adapted approach allows us that in patients who get to an auto transplant, if they don't benefit from that procedure, we can take these patients to CAR T-cell treatment as a third strike to try to cure them. But I'm skeptical that you can do an auto transplant after CAR T-cell treatment fails. Anecdotally, it has been done, but I think in all comers, yeah, it is not that straightforward. So I think that sequencing of treatment is important. So I hope that in these 20 minutes, I at least convinced some of you that while availability of cell therapy and second-line treatment is extremely exciting, I think we are not at a point where we can apply one treatment to every single patient that enters our door. So at this point, I'm gonna stop. I'm grateful for your attention. Again, grateful for your invite, and looking forward to the Q&A session.